Hello, everybody. Welcome back to the show. This is the Science Dispatch podcast. My name is Cameron English, your host as always, joined by the faithful, talented, thoughtful Dr. Chuck Dinnerstein, Director of Medicine at the American Council on Science and Health. Chuck, it's great to see you. It's been an eventful 24 hours, to say the least.
Yes, because we're speaking the morning after the election. That's what must have been momentous.
Yes, indeed. By the time everyone hears this, only God knows what could have possibly happened. So if you're listening to this a few days from now, we're making no predictions. I've been informed by reliable sources that the apocalypse has begun. So far, the signs are minimal, but as I said, we'll see what happens. In the meantime, we have a story by Dr. Dinnerstein to discuss, very simply titled, Chasing Cholesterol. This is from the middle of last month. Chuck, let me read this introduction here and then take it away and explain what we're talking about. So you write, if you remember the ambitious goal of the American Heart Association to slash cardiovascular disease by 20% by 2020, that didn't quite happen. The fight against heart disease has stalled, leaving experts scratching their heads and waving the prevention flag harder than ever. We're really good at achieving some metrics like cholesterol numbers, but maybe not so great at solving the actual problem. Okay, lots to cover here, Chuck. Why don't you jump in and explain what we're dealing with here?
Okay, so the basic premise is that for the last 15, 20 years, we have really been focused on lowering the bad cholesterol, the LDL cholesterol, as a means for bringing coronary artery disease, cardiovascular disease, under control. And for a good chunk of time, we were making significant progress. You could see on the curves that it was coming quite down. But in the last 5-6 years, that curve has flattened out, and we don't seem to be making the same kind of progress that we've done in the past. And so there's been a lot of lamentation. Actually, it would be good to go along with today, and ripping of clothing and chewing on ash about what the cause of this is. And I just happened to be reading at the same time some other material, and I came across what was called Goodhart's Law, and I thought that it made perfect sense in this setting. And Goodhart's Law says that when a measure becomes a target, it ceases to be a good measure. And I think that really captures the problem with cholesterol. 15 years ago, an elevated cholesterol was a reasonably good measure for people that were at risk for coronary artery disease because statins had arrived on the scene, but they were not being as widely used as they are today. And so LDL cholesterol measurements, which are easily obtained, became the proxy for improvement in coronary artery disease, because that takes 15 or 20 years to develop an improvement overall. And you can see a drop in cholesterol within a few weeks if you're putting on a statin. So that's become the surrogate. And what's happened over time is that surrogate is no longer very useful as a measure. And that was really the sum and substance of it. And then I pulled another thought, which comes from the world of AI, which is the concept of overfitting, which is that a model works very well on its training data, but when you put it out in the real world, it falls apart because the training data has made it too brittle. And I think that this goes along with that idea about Goodhart's Law, that the LDL cholesterol was a good measure for a while, but by applying it to everybody and by increasingly trying to lower the levels lower and lower and lower and lower, we've lost sight of its role as a proxy, and we've overfitted the model. And so it's no surprise that we're not getting the gains in treating the disease that we had in the past. And so I think that was really the sum and substance of what I was trying to get at in the article. But the article presented a number of ways that we've come up with for treating the problem, and the experts that are addressing cardiovascular disease, the cardiologists, talked about all the usual things that we need to do. We need to increase prevention. that it's very difficult to make people follow healthy eating habits, that there are cheaper alternatives, especially something like the poly pill, which does have a lot of advantages. And then, of course, there's the usual structural barriers to access, and we're not making enough investment in primary care. But nowhere along the way do they consider the fact that maybe at this point we shouldn't be chasing cholesterol anymore, and we should be looking at other ways to improve the outcome. So that was the gist of what I was trying to say.
Well, if you're the American Heart Association, you thrive on donations from wealthy people. That's not a message that's going to sell, right? You need concrete steps. You need impact. So not to say that they are entirely motivated by finance, but the reality is they have salaries to pay and they have lights to keep on. And so maybe that to some extent is influencing the recommendations.
It's not only them. I mean, all of these quality assurance programs, all the programs where the federal government gives incentives to health plans and to insurance companies to improve care involve measuring LDL cholesterol. So it pays providers literally to measure this and to put people on the meds, which again makes good sense, but it's not at this continuing to lower the level to its zero is not going to end cardiovascular disease. You're going to have to look at a lot of other issues that are involved in it, the genetics, not exercising, smoking, any number of other components.
One of the things that's positive that you mentioned that most people in this discussion won't is that we're much better at keeping people with cardiovascular disease alive. So because they have not shuffled off this mortal coil as soon as they used to, the numbers may look worse overall, depending on how you splice them and so forth. But, if the measure is keeping people alive and, perhaps improving their quality of life to a certain extent, even if they're still sick, we have made some progress. What are your thoughts on that?
Absolutely. We're very good at creating greater chronicity to chronic illness. And in a lot of areas, that that's a very good thing. I mean, I think one of the big breakthroughs that we have in treating cancer is the fact that for many people, cancer is no longer the threat of death that it was 15 years ago, because we have such a wide range of therapies that we can apply that after one therapy fails, there's 2 or 3 more that can be brought to bear on it. Same thing with HIV. I mean, HIV used to be a death sentence and within a year or two of getting it. And now with the whole range of antivirals, it's something that now becomes chronic and that we can live with. And depending upon how you measure it, if you measure the new onset of cases of HIV, that will give you one sense of how things are going versus if you look at the life expectancy of these individuals, which will give you a completely different look at whether you're making progress against the disease.
Another thing, I don't recall if you mentioned this in the story or if AHA mentioned it, but smoking rates are at an all-time low for both for adults and children, which is significant. So, projecting into the next 30 years, provided nothing dramatic changes, then it's likely that heart disease rates are going to decline, right? So even if
no, if you check with the literature, they're only going to get worse. What are you crazy? No.
More studies needed, of course. Yes.
Yeah. More studies will be needed, and we'll need more drugs. But you're right. Is that the cause of disease remains dynamic, and with the reduction in smoking, and the reduction in cholesterol, we're going to see a lowering of this. And now it gets down to the fact that if we've treated these simple problems, we're going to have to start looking more at some of the other hardcore issues that go along with it. And of course, then we're going to start talking about things like you're going to have to start to exercise. It's just not going to be, a good way around it. We're going to have to talk about the role that diabetes has to do with coronary artery disease, and you can argue glucose dysregulation is a more general category, or pre-diabetes, that we need to talk about other parts of our diet besides the part that impacts our cholesterol. We have to talk about the fact that everybody is overweight.
And that's a good point, and it leads me to something I wanted to talk about. Using myself as an example, because I'm not trying to put, I'm not trying to single out one group and say you're fat, it's your problem, right? But I remember when I decided to tackle my weight years ago, it was just realizing that if I didn't make changes, my life was going to be far worse than I was willing to tolerate. But there was no ad council message, and there was no tweet I was going to read or whatever, like whatever sort of influence, the fact that I had access to a sidewalk or a safe park, which is what one of the experts in your story points out. None of that was the incentive I needed. It took me effectively forcing myself to change. And I think what you're sort of getting at here is that we just don't know how to do that at a policy level. There's just no way to incentivize people short of locking them in a hospital ward and portioning out, the chicken breast and broccoli that they can eat for the day. It's just...
Well, fair enough. I think it's how do you scale therapies? On the one hand, we want to scale it because then we can apply it across the board. And on the other hand, we want to personalize it so that you do it. So, and I gave short shrift to talking about the poly pill, but the poly pill is a very interesting combination of basically 3 medications or 2 medications, depending on how it's formulated. One to treat cholesterol, another one to treat platelets to lower their ability to cause clotting, and a third pill to lower your blood pressure. And they're given as a single pill. And this is very popular as a treatment modality in the middle and low income countries because you can turn this pill out for about a penny or 3 cents. It's cost nothing to make. And as it turns out, it's just about as effective as all the 3 separate medicines and congeners that we take in the U.S. So if we're looking to scale things, there is, we could all switch over to the poly pill in that at-risk group, and we would probably see some significant improvements there, as well as in lowering the cost of healthcare. But I don't think that'll be coming soon.
So if I'm hearing you right, we just need to drug this away, right? We're not going to be able to incentivize the behavioral changes in enough people, short of giving them a drug that's going to put them in a better metabolic state.
I think it's on an individual basis. Everybody has their, I don't know, their come to Jesus moment. You had your come to Jesus moment. In terms of that, because I live more in the world of denial, it took longer to get there. And even though I have a far deeper understanding of cardiovascular disease because I had to go to school for 4 years and residency for another 7. So despite that, everybody comes to it in their own pathway. So now that's one of the arguments I think for having a relationship with a primary doctor, primary care doctor, whatever, a cardiologist, whoever it is that you get your healthcare advice from besides Dr. Google. Because I think in that setting, once they know you well enough, they will be able to help you identify the levers that let the scales fall from your eyes and say, gee, this might not be such a bad idea. Because we all have that bias of putting things off for another day. I mean, and this, of course, is about to age me, but that's just the way it goes because I'm old. From the old Popeye cartoons, there was this, Wimpy was the guy who always was willing to trade a hamburger today for payment on Thursday. And that's the way we treat a lot of our healthcare needs. I'm more than happy to worry about it in a few weeks. It's called temporal discounting. That's the official term for the bias that we're talking about.
I want to make sure people don't discount the access to healthcare point. We talked to Dr. Paul Offit several months ago, and one of the points he made about the pandemic in his book called "Tell Me When It's Over," when we were talking about it, is that it was access to healthcare that correlated very tightly with someone's willingness to get a vaccine. So in Florida, for example, which as far as public health was concerned, this was the dark lands that you never go to, where all the evil resides. Their vaccine uptake was quite high because it's mainly old rich people who have access to healthcare, who understood the risk. Whereas in rural parts of the country and some urban centers, there's limited access to healthcare, and of course their uptake of the shots was much lower. And so, to your point, I think that's probably one of the key ways that we can improve things.
So 2 points. We call Florida God's waiting room.
It's either Jerusalem or Miami is the promised land. Is that
among other things, it is the promised land in that regard. But you're right. Having a relationship with a provider allows for the ultimate impersonalization of healthcare. And unfortunately, for a number of reasons on both sides of the table, that's becoming, unfortunately, a distant relic of what we were able to do 30 or 40 years ago. And I think that we're going to find that it's a tremendous loss, but we're not going to notice it until it's been long gone.
All right. Well, we'll see what happens. I know. It's just, I wasn't even going to mention it because it should go without saying at this point. We bring up big problems with challenging solutions that we can't provide. And then maybe it will inspire one of you guys to go fix it. So once again, Chuck's article, it's called Chasing Cholesterol. It's at acsh.org. If you want to get the stories that we publish in your email, go up to the website, go to the subscribe tab, punch in your email address. We'll send you everything we publish. And we talk about the most popular stuff. So when you show up for the show, you'll know what we're talking about and you'll get a little bit more out of it. So with that, thank you so much. We're on Twitter. It's at acsh.org, and I'm at CamJEnglish. All the best, everybody. Good luck in the apocalypse out there, and we'll see you next time.